So I'm going to switch it up a little bit. I'm going to talk a little bit about some of the work my lab is doing, trying to see how we could make brain imaging more accessible and also more cost effective. And I'm going to talk about what we're doing in neuro-oncology. I'm in the neuro, so I can only look above the head. So in terms of the global trends, when it comes to brain tumors, incidence rates we're not sure what's happening in most of the lower half of the continent, but in terms of incidence, it's obviously quite high here. But when you look at the mortality rates are actually quite increasing in the global south. So the death rates are much higher, sometimes even 4 times higher compared to the global north. And that's one of the reasons why when you look at where the therapeutics, so where is the treatment going, it's not going to where the burden is. A lot of the countries in the global south, including Africa, and I'm going to talk a lot about this continent, don't have access to the therapy. And one of the reasons why they don't have access to the therapy is because they don't have access to the diagnostics. And the reason why they don't have access to diagnostics is multiple reasons. I don't have time to explain all of that, but one of the main reasons is that patients show up late. They also have really older and not well-utilized imaging systems. And the biggest issue with that is that they don't also have really well-trained personnel. So I'm going to touch on this a little bit. For those that are not familiar with neuro-oncology or brain tumor imaging, there's multiple different imaging modalities that we use. We use, trying to find my, so we use CT. MR is essentially the workhorse and what I call it, the bread and butter of neuro-oncology. There's some PET imaging, but mostly, at least within the clinical space, we do a lot of multi-contrast MRI. And if you want to look and learn a little bit more about the imaging modalities, there's lots of really nice review papers to look at. But what I wanted to point out today is that it takes one radiologist to look at most of this multiple contrast, sometimes reading the MR and the CT. And if we talk about where the scanners are, like I mentioned, it's not where the disease burdens are. If I were to compare radiologists in, let's just use the US and just pick a country in Africa, we can see what the ratios are. So one thing we're trying to do is figure out ways to use, well, I'm going to talk about AI, ways to use artificial intelligence to maybe try to develop cost-effective, so cost-effective meaning being able to have these imaging techniques readily available so that they could, A, be able to read it, acquire faster, also improve the image quality. And so I'm going to talk about what my lab is trying to do. So AI has been a long time being used in the clinical pathway for neuro-oncology, preoperative, intraoperative, or postoperative. In terms of where I land and where most of the work in imaging happens, it happens in the computer-assisted diagnostic phase. And there's lots of ways of using AI to do this. I'm going to talk a little bit more about what we do within the computer vision and what I call it neural networks in terms of imaging. For the past decade or so, we've been aggregating data across mostly from the global north, from the US. And these data sets have been used to develop multiple and countless machine learning methods, mostly deep learning methods for brain tumor segmentation, for brain tumor classification. The long short of it, and this is a nice meta-analysis showing that the machines are getting just as good as radiologists in terms of at least being able to segment the tumors automatically, and also being just as good as being able to classify the tumors with some minor variants. And this is only because that we've had really rich data sets that we've made available publicly that people have used to run stuff like challenges, like the brain tumor segmentation challenge that's run at McGill every year. And these have actually allowed us to start to create really nice methods. The question is, how well do these methods perform when we try to apply it across the continent? How well are they generalizable? And the long, short answer is that they do fail. So this is the work that my student did using essentially simulated data. We started off with simulated data that we simulated to match the image quality, noise quality, the resolution of MRs. And this is for any lesions. We did stroke, we did epilepsy, and we did brain tumors. And here I'm showing you 3 cases. I can't remember which these cases are. I think they're all brain tumor, maybe one stroke lesion. But these are the top performing methods from the past, brain tumor segmentation challenges. So these are methods that have been benchmarked and have been sort of thought to be the state-of-the-art methods when you apply it to data sets that are typically from most of the world where we have lower scanners, so 1.5 to MRI scanners, when we have poor image quality, you see that they do fail. Now, what we try to do is we try to not include them in our training methods. And when you include them in your training methods, you see that they do perform a little bit better. And the reason why they do fail is because, like I said, most of the images that are used in developing most of the AI methods we use are high resolution. They come from 3D scanners. They have rich information, we have multiple different contrasts, and there are thousands of cases. So the brats now have, I think, 4,000 or so cases across multiple different glioma, meningioma, pediatrics, and all of that stuff. Now, if you include most of the world, because 80% or 70% of the world don't have access to 3 Tesla scanners or even use it clinically, or some of them don't even have access to contrast imaging, you see that you have lower resolution, less information, and few cases. And so what we're trying to do here is we're trying to figure out ways of being able to use the current work environment, clinical environment, the low scanners, the few radiologists, whatever that the work environment is, we're trying to figure out ways of optimizing that so that we can be able to see if AI can be not only cost effective, but actually can start to change the clinical outcome. So what we've decided to do is to do 3 things. One is to just meet them where they are. So optimize the imaging infrastructure, train the local expertise, and what I mean train a multidisciplinary of them, and then put them in a collaborative network, and I'll show you how we're doing that. I mentioned earlier about meeting them where they are. The scanners, like I said, are mostly, so they still scan clinically on 0.3T obsolete scanners that we actually don't have anymore. So those permanent magnet scanners, they still use that. A lot of the scanners in private practice, so research and trying to do, implement or use AI or develop AI, there becomes a little bit of a challenge. And like I talked about, protocols being suboptimal. If you're using an old Mindray 0.3T scanner from 2000, you don't have diffusion-weighted imaging because Mindray does not care about the scanner anymore. They've moved on. So that kind of stuff, you need to figure out how to meet them where they are. Train experts. So in order to do something like just a simple task as image segmentation or even classification, there's a whole resources that go into that besides the data. Obviously, the data has to be curated somehow. You have to have a ground truth. You need experts to create that. You obviously need some amount of data quality. You need techs that are well trained to scan, garbage in, garbage out. Obviously, you need the computer scientists and physicists as well to make sure you have an informed models. So you have a whole village it takes to be able to do a simple task as image segmentation that we often do very well here in the North. And don't take for granted the fact that we have all of these resources to help us do that. Another thing is that, like I mentioned, one of the reasons why we're having a bit of a push towards hopefully AI being adopted into brain imaging is the fact that we have a lot of institutions that have collaborated to provide data sets, collaborated to annotate those data sets, and collaborated to benchmark them. So we have to be able to create these networks across Africa where oftentimes you don't know where your colleagues are. There's no website, stuff like that. So we have to figure out how to be able to do that. So how are we doing that? Essentially, one thing we did was we got a little tiny grant to create just a brain data set and make the data set publicly available. We decided to use that grant to do a little bit more to answer all of the issues that we talked about, the issues with infrastructure, the issues with personnel training, and even policy, being able to figure out how to do research in a private setting. And so with that tiny little money, I partnered with a radiologist in Nigeria that owns a private clinic that has a 1.5 to a CT scanner in his clinic. This is a storage space. I came to him with the idea of, let's just try to see if we can do something. Model to bedside, whatever you want to call it. This is where most of the patients tend to go. And so we turned the storage space into an AI lab. We have 2 high performance cluster computers. We have a training space. There's actually a seminar room across the hall. There is a molecular lab that's been built up with microscopes and stuff, so we can start to do pathology imaging. And there is, my mouse again, this wall here actually has a small server room because they do a lot of, they actually built an in-house PAC system. And so from this lab, we've been able to run a series of summer school. I'm going to talk about this in a little bit. This is, again, train those personnel. And we've been able to aggregate with clinics around the country and across the continent, aggregate the rich data sets that's now publicly available. And that data set is here. We've been able to demonstrate, at least with a few of the cases. One challenge we had is we started off with 14,000 brain MRIs. We were looking for gliomas. We found about 400 to 300 glioma cases, or what we thought were glioma cases, because again, they're archiving systems, so not archiving systems. They're more like drop boxes because they don't have the capacity to store a lot of information, a lot of images. They're not structured. And so from that, we were only able to get a few cases. So we lost about 70%, or we were not able to use about 70% of our data set. But with that, we're able to provide at least some certain point of data sets that resemble and are very similar to what is out there right now. So very similar to the current standard for, at least for imaging standard in terms of quality. We've run a couple of challenges. This is one from 2023. We did one just a couple weeks ago, October 5th or 7th was when we concluded that. And the paper is out there, heavily cited. So if you want to learn a little bit more about the challenge and how we put together a data set, the paper is out there. One thing that we're very proud of is, I'm going to talk about this a little bit, is that we had teams from Africa participating for the first time. And I'll tell you how these teams came about. And one of them, thanks to Shirin's fantastic student mentoring them, actually developed a method that was ranked second next to NVIDIA. So we're very happy to be standing next to NVIDIA, showing them that we could make these models once we train them. The data set is open and available on the National Cancer Archive. This is the first brain imaging data, so CT or MRI, from Africa that's available publicly. So we're going to try to make more of that and release more of that. Training is very important, like I mentioned earlier. So we've created this program where we're actually trying to train experts where they are. So essentially train them on how to optimize the infrastructure. And we've created this curriculum that takes them through a 3-step process, teach them all the, foundational knowledge they need to know about MR physics, about clinical, what is the clinical features of brain tumors, how to do coding. So this is a long 8 weeks program, is self-paced and virtual. And then we bring them together in a 1-week hackathon. We give them past data sets, past model, teach them what the codes are. They've learned about how to code. Now take this code, try to put it back together and see what it does. And then we actually get them to use that knowledge right away. So we actually enroll them into the challenge and get them to sink or swim. But they actually always end up swimming because we've given them all of the background information and the skills that they need to do. We are grateful to Compute Canada, so we're able to actually give them access to Compute Canada to be able to develop their methods. And I've done this for the past 2 years. The numbers are there. The numbers are growing. We were able to go from 170 trainees to 234 because most of the trainees from 2023 came back. So that's a train-the-trainer model to help us scale up. And we're training a whole bunch of clinicians. There is a neurosurgeon. I think is the first neurosurgeon trained in Benin. There's the first neuroradiologist from Tanzania. They're all part of a training program. And like I mentioned, last year, we were able to take home the second prize. That's us at McGill in Vancouver last year. That's us at McGill in Morocco this year. And in the front row, except for him, and them, the rest are all radiologists, and that's a neurosurgeon. So the papers are there to take a look. I'm just going to give you one example. This is a method that was developed last year by one of our groups. The idea is to take this segment entity model, which just came out actually in April of 2023. The training started in April of 2023. So a week into the training, during that tutorial, one of the students asked, "What is SAM?" I had no idea what SAM is. None of us knew what SAM was. And so we had to figure out what SAM is and teach them what SAM was. And so they wanted to actually quickly apply that method. And what they did here was segment entity model, essentially say foundation model that uses, think about it like a ChatGPT for images. So you can enter any prompt, points, box, or text, and use that to segment any image, any object within an image or within a field of view. And here they're trying to essentially use this to segment brain tumors by actually fine-tuning the encoder and using a method that actually takes in priors. So priors are previous brain segmented masks from a larger data set, so from the previous rats data set, and then try to see if that would be able to segment an unseen data set like the lower quality Africa data sets. And it did a pretty good job. So this is the ground truth. This is the method with SAM, just as is out of the box. And this is the SAMBER method showing much better improvement once you fine tune it. All of the method models that have been developed, about 10 of them from 2023, they're all in open source on GitHub, and the 10 from this year will be released, I think, within the next couple of weeks. Most of the papers on archive. Quickly moving on, one thing we realized with the data set is images were really, really poor. And one of the reasons why they're really poor is because they actually don't really know how well to scan. And one thing we wanted to do is create a standardized protocol. We are not the first to do this. Marion has done this. Marion Smith has done this with the ESNR. So there is a brain tumor image protocol developed by the European Neurology Society. We're actually trying to learn from them and at least find what is the minimum standard. Minimum meaning that the minimum required images that they could acquire, is it T1, is it T2, can they do FLAIR? So we have to do a series of stuff which starts with actually a survey of how do they practice across the continent to be able to figure out a minimum standard and then have a consensus protocol that we can harmonize across a few sites. We're actually able to do this right now because remember, we trained a whole bunch of radiologists across multiple different countries. So we just have to go back to them and get them to apply those sequences. We're actually in the process of releasing our practice survey to start figuring out how they scan and develop that minimum standard. For time's sake, I'm just going to end here with, if you want to improve this in terms of therapy, theranostics being one of them, you have to be able to first figure out how to optimize the infrastructure, train the local experts where they are, and put together a collaborative network. Thank you very much.